Welcome to Parallax by Ankur Kalra, a podcast produced by Radcliffe Cardiology to bring you a new angle of all things cardiology and the best from the US Cardiology Review. Published every second Monday, Ankur Kalra, MD, interventional cardiologist at the Cleveland Clinic in Ohio, USA, speaks with legendary cardiologists, reviews late-breaking trials, and interviews authors of our latest and best US Cardiology Review articles. We call them #audio articles. Parallax is the effect whereby the position or direction of an object appears to differ when viewed from different positions. So this podcast is your fix of reliable updates on all things cardiology by someone from a non-traditional background who is always looking at the industry from a new angle. Now, here's your host, Ankur Kalra, MD.
Hello, everyone. We are in episode 18 of Parallax. This has been quite the year for us at Parallax. We started this show in 2019, and the year has gone by so quickly, and I've had the distinct privilege of interviewing so many exemplary and legendary cardiologists on the show. This is the finale show for this year, and when we were discussing what the theme should be for this show, our team recommended to do a roundup of what has happened in cardiovascular medicine and cardiovascular diseases worldwide, with all the new data that have come out on multifarious disease conditions that we see as cardiologists on a day-to-day basis. And then, we also discussed as to who should do it. And, I think that the guest who I have with me on the show today, clearly was the winner when we were picking up, who we should get on the show to help us round up the year for us. So it is my absolute honor, a privilege and pleasure to welcome on the show Dr. Nijjer. Sukh Nijjer is a consultant cardiologist. He's an interventional cardiologist at Imperial College in London. And, we've been following each other on Twitter, and, it was my distinct privilege and pleasure to actually see him in person this year at TCT, which was when we connected and, we decided that we would do a show together. So Sukh, welcome on the show.
Thank you so much, Ankur. It's a real privilege to be here. I was really so glad to get your invitation to come on the show. I've been listening to it, and I've been really impressed with what you've been doing.
Oh, no, thank you. Thanks for listening, and thank you for all the support, and also for sharing, our existence with the Twitter world. So, before we get started on the roundup episode, would love for you to talk a little bit more about yourself and, your background and, what was your journey into becoming who you are now.
Wow.
I think our audience would be very interested in that aspect as well.
Well, that's a super big question. I'm an interventional cardiologist. I grew up in England. I was born in the UK, and I grew up in England, very close to London. And I have what many in the US would consider a very middle class background. My father was what you guys refer to as a blue collar worker. My mother was a secretary in a doctor's surgery for primary care doctor, and they worked very hard. They put me through school, and went to a very normal, modest school. And I went to university. I went to University of Bristol, which is a very good university in the United Kingdom. And then I came back to London, where I did all of my internal medicine. I rotated through a lot of the prestigious places in London. There used to be a pathway in London that you could go between all the various hospitals, and there was a clear path if you wanted to be a cardiologist. And so I went through all the different jobs. I worked at Harefield, I worked at Brompton, I worked at the Hammersmith, and then I became a registrar, or what you guys would call a fellow, I suppose. And during this time, I got the real academic bug. and I came across a fellow who you may be familiar with called Darrell Francis, Professor Darrell Francis, who he wasn't a professor at the time, and he took me under his wing, and we worked on a number of projects, and then I started a PhD under his supervision together with Justin Davis. And you may have heard of Justin, so it was a really unusual time because he was also a fellow at the time. He was a little bit more senior than I was. And I joined colleagues of mine, Shai Sen and Ricardo Petracco, and we just happened to get quite lucky because Justin was in the process of developing something called IFR, instantaneous wave-free ratio, which is a physiological parameter, and for detecting coronary stenoses and assessing its significance. And we worked incredibly hard, and this was a technology that then ended up being licensed by a company called Volcano, now part of Philips. And then that kind of really set us on a particular path where we just did, a huge number of studies. So we did a lot of basic science. I spent a long time in front of a computer programming things in the background, as did my colleagues. And my particular area was that I developed the co-registered pullback. So if you've ever used an IFR and you've pulled the wire back and you've plotted the pullback trace, this was something that I spent a long time working on. And following my PhD, I then did interventional fellowship, and then now I'm attending at the Hammersmith Hospital, which is part of Imperial College, which is where all the cardiology services are. And I also work at Chelsea and Westminster Hospital, which is a very different kind of hospital. It's what we consider as in the UK as secondary care. It's principally perhaps a larger population of people, but broader disease process. So I have an interesting mix of seeing very general cardiology, lots of interventional cardiology in secondary care, as well as seeing really complex things at the Hammersmith, whilst at the same time trying to juggle some component of academia and manage fellows and work alongside my fantastic peers such as Shai Sen, Ricardo, and Rasha Alami. And we're kind of forming the face of the Hammersmith now, which is a real change because we're all much we're of the same age and we've come through at the same time. So it's like a totally different face to the hospital than before.
Yeah, no, it's fascinating. I mean, some of the names you've just shared with us would be places where I'd love to visit. I mean, I obviously have seen a lot of research being published from those hospitals. Hospitals like Royal Brompton and
absolutely, yeah.
Even Chelsea, Westminster. I mean, these are all very well-established names in the academic world of cardiovascular medicine. I'm sure you're aware.
Yes. Yeah, it's a real privilege to work in all these places. London's a slightly unusual place. It's a very cosmopolitan, metropolitan place. And it's great to work in these places because you get a balance of lots of different types of patients, and ultimately what you want as a young cardiologist is just sheer volume of cases, and we're very fortunate to work in places which have that.
Yes, I was in London in 2018. That's when I started my master's at the London School of Economics. It's an executive program, and it was the first time I've been to London a couple times before, but I haven't really stayed in London. So it was the first time I actually stayed in London for about a couple of weeks, and got a chance to explore the city a little bit on the weekend. And what really struck me, obviously I've known London as a very cosmopolitan city, and a city with multiple ethnicities, great food, also obviously a lot to see, a lot of history. But I think what really struck me was, how organic the city is. It's.
You mean disorganized? That's a polite way of saying disorganized.
Yeah. No, it's not disorganized. I think there's just an organic flavor to the place, which it makes it a lot more, special. It just makes it very natural.
Yeah, absolutely. So a lot of the cities in North America are planned and designed in a particular way, which they're designed for convenience and for getting people from A to B. London's definitely not like that. Traveling across London, doesn't matter where you're going, it'll take an hour, and whether it's by car, by train. By using the tube or any of these other forms of transport, it's a big city and it's sprawling. And it can be tricky. So it's an interesting place to live and work. It's unfortunately incredibly expensive, which has its own pressures. But we are blessed with the fact that there are so many good hospitals, plus lots of super bright people. And the one thing that we really count our lucky stars for every single day is that our fellows are absolutely wonderful. So we've had some really, really fantastic fellows who've produced some amazing work and continue to do so. So you would have seen things from fellows such as James Howard or Yusuf Ahmed or Chris Cook. And these guys have continued to really push the envelope forward. And we try and create an environment that we're supporting them and pushing them forward, because ultimately, if they're doing well, then the whole team is doing well, and that's how we try and engender that process in our centre.
Yes, no, that's very heartening to hear. I think I'm in the early career phase, and I remember being a fellow, not too long ago. Shortly will be 3 years. But it's so important for faculty, young faculty or established faculty to continue to harness, the energy that fellows bring to a program or to a place, and they're brimming with ideas, and they're obviously very energetic. They want to make a name for themselves, and they just want to dive deep into the academic world. And I think that's what also keeps the faculty very engaged and very young and very involved. That's how I've always perceived the advantages of an academic place. Would you agree?
Yeah, absolutely. I think when you're a fellow, you have a degree of naivety. You don't understand the limitations of things, and that's it's actually a good thing to have, because you're willing to try something that other people will have dismissed. I think as you get older, you get a little bit more cynical. So it's good to have fresh, new young people come, and we've had. I just had yesterday some new people coming to pursue PhD ideas, and so it's an exciting time to try and to find projects for them. And we're very lucky because people like Professor Francis are very supportive and try and structure our program so we support the academic component. But at the same time, we're very keen for our guys to become clinically excellent. And for myself as well, when we're doing cases, we want to do complex cases. We want to try the latest techniques. We go to meetings. We pick up on new techniques. We share ideas. You mentioned Twitter earlier. We learn so much by sharing things with each other. And then, it's important for us to try it, and then for our fellows to try it as well. So I think it's a circular thing where everyone feeds back into each other and helps improve what we do.
Yes, I completely agree. So moving forward, let's dive in to 2019 for cardiovascular medicine, and probably begin the conversation with the first major meeting of the year, which was the American College of Cardiology meeting.
Yeah, and New Orleans. Yeah, absolutely. So what a year overall, Ankur. It's some amazing big studies presented throughout the year. Really altering the face of cardiology, I would say.
Yes, so it started, I think on a very high note with ACC, and the two studies which were heavily anticipated. I think recruitment was very prompt, and I think kudos to the investigators who made these trials happen. They both were New England Journal of Medicine papers. We're talking about the low risk TAVR studies, partner 3 and the Evolut Low Risk. So yeah, I'll have you sort of walk the audience and listenership through these studies and tell us what you think about them.
Yeah, so these are altering the paradigm of treating patients with TAVI or TAVR, as you would say. And the key points of these study was to alter the risk of the patients that went into them. So the previous partner studies had very high surgical risk, very high STS score, very high surgical scores. But partner 3 and the Evolut Low Risk study basically took much lower risk patients, not necessarily younger, but lower risk. And what they were able to demonstrate in this cohort patients with really low STS scores, I think partner 3 was down to kind of less than the STS score of 4, in an average of around 70, was that there was a big reduction in death, all-cause stroke, and rehospitalization. And in partner 3, we're seeing rates in the TAVR group of around 8.5% versus 15% in the surgical arm. And this is made up of all the different components, so death, stroke, and rehospitalization. So this is an important factor. So all 3 components of the composite outcome are all trending in the same direction. So when we see that the overall effect is highly statistical, significant, that we can believe it as well. Obviously, as we move into lower risk cohorts of patients, then we start having to worry about what the longevity of these valves are. And that still is to be learnt about, and we're still understanding how that plays out. And we want to know about paravalvular leak, and I'd say the new devices that we have are much better than the early generation of TAVR valves. And so if we can solve paravalvular leak and we can solve the need for permanent pacemaker, then we will have an incredibly useful and good technology, which then in itself can create a difficult situation for practicing clinicians when you have low risk patients asking for TAVR rather than traditional open surgery, and where we then start to have very nuanced conversations with our patients. And if someone asks me, what would you like to have, a procedure that's done through your leg and you could potentially go home the next day or the day after, versus having my chest opened, then it seems very intuitive that most patients will choose down the TAVR route. But there will still be a cohort of patients that are best served with surgery, and it's just trying to identify those patients up front, which is going to be the next challenge for us.
Yes, I agree with you. I mean, we've started having these conversations with our patients. Patients have come to us, truly low risk patients, mid 60s, early 70s, otherwise healthy, have senile calcific aortic stenosis. And, we've, at our center, we systematically use the cerebral embolic protection device in all our cases.
Right.
Again, is a subjective discussion and debate. If you look at the overall practice pattern and trends, and even the overall stroke rates, as the technology has improved and as operators have gotten better, the stroke rates have actually declined quite a bit. If you look across the spectrum of all the TAVR studies that have been published, over the span of a decade.
For sure. We've got better at doing them, haven't we? I mean, this was initially when we started. I remember when we first started doing TAVR in our hospital, this was still a very new approach, which required quite a steep learning curve and understanding the various processes. And now it's something that's routine and it's becoming increasingly minimal. We're reducing the number of wires and kit in the patients. And all of these things make subtle differences. Plus, I would say the patient cohort that were originally in these studies, so certainly the cohort that we were doing at the Hammersmith, very high risk, true surgical turndowns. And I think that was almost certainly a driver of major events in these patients. Certainly, the one thing about starting a TAVR program is if you have to have a true surgical turndown, then suddenly the surgeons are doing a lot more AVR than they were before. That's certainly what we've seen. Our surgeons suddenly want to take a lot more patients on because they otherwise worry that their numbers are going to go down.
Yes, so I just want to take this opportunity to actually ask you about the practice patterns after the publication of these 2 papers in the New England Journal of Medicine. I know it was recently approved for low risk even in Europe.
Yeah.
I don't know if London falls into that category,
Yeah,
or is it
yeah, absolutely. So we have a very comprehensive TAVI or TAVR program where every patient is discussed in a heart team meeting. So patients will be seen by TAVR operators. They have to see a surgeon, and they have to have a detailed discussion with the surgeon. The surgeon has to agree that they're a surgical turndown. And in cases where there's equipoise, there will be a fairly robust discussion either way. And we will often make a shared decision with the patient. So it's often the difficult decisions are in the younger patients. So the problem with doing it in a 60-year-old is that we don't know the longevity. And if the valve wears out, then okay, we can put another a TAVR inside that patient, say in 5 to 8 years, say. But for example, if we've chosen to put a core valve into a patient and then we put another core valve in, are we going to be able to get to the left main for when they have, an MI or something like that? So can we get coronary access through 2 layers of core valve? So these are the kind of new complex decisions that we're having to decide. But in terms of what we're actually doing and in terms of the patients we're taking on, I think we have followed the findings of these results, these studies, and we're taking lower risk patients for sure. And what we find is if you take a lower risk patient, then the outcomes are actually better because, of course, there tends to be less vascular complications and less other complications from poorly patients with frailty. So I think this is a technology that's really now coming into its full, but we still just have to be a little bit careful because it turns out that not every one of these devices is equal, and there are some nuances that we're going to have to think carefully about.
Yes, and just talking about those nuances, how are you selecting, in low risk cohorts, how are you selecting balloon expandable versus self-expanding devices?
Well,
is there a strategy, like an anatomic strategy, or is there?
Yeah, so we have two. Our team uses either the Medtronic self-expanding valve or the traditional Edwards balloon inflatable valve, and they've got really good experience with both these. And so they will decide at the MDT, the multidisciplinary team meeting, and they'll predominantly base it on the anatomy and the presence of the coronaries and the sizing. These are all important factors. And we haven't moved on to do some of the more advanced techniques that are coming through now with like basilica and things like that. But we've done some transcaval cases, and so these are fairly advanced, complex techniques, and so this then starts altering who can have what, and I think that's an important factor. All our patients get CT; they all get very comprehensive review by vascular surgeons, and we have a specialist radiologist who specializes in interpreting these CTs. Who does it alongside a cardiologist who reads CT, and this then helps decide the approach, the route, and the valve that we're going to use.
Yes, it's very similar to what is done in the US in terms of having committees and heart teams systematically go through each of these cases, together as a team, review all the imaging, all the diagnostic data, and have that discussion with the patient, together with an interventional cardiologist and a cardiac surgeon in the room together with the patient, having those conversations. I think it's very heartening, and it's a great time to actually be an interventional cardiologist, where you and I have actually seen the genesis and the development of this specific technology and how it has altered the game. I mean,
for sure, absolutely. Everything in the time that you and I have trained, coming through from if you think when I was what we call houseman, or you guys would say intern, we were thrombolizing MIs, and so we've moved from thrombolysis to primary PCI, and then PCI with very simple lesions to increasingly complex. There was a time when I remember that people would gather around to look if someone was doing a left main, and it was people would talk about it for a couple of days afterwards. And now I'm routinely doing left main angioplasty on my cath lab list, and no one bats an eyelid. So this is just the evolution of generally how good things have got. I think we forget how good things are, and it's easy to kind of fall into the melancholy of, there's bias in this study or there's difficulty in this study, when reality is that things are actually very good.
I agree with you. So moving on from the TAVR space to another study, which was, I thought was an important study, and that was the SAFARI was one, and then the other one was COAPT.
Yeah. So SAFARI is very interesting because SAFARI looked at access site for interventional cardiologists, particularly in patients undergoing STEMI, so primary angioplasty. And the received wisdom over the years has been that radial is a better and safer route. And obviously you have huge proponents of radial first. We have Sunil Rao and many others. And in the UK, we've got many people who've really preached this. And in the UK, radial access has now reached, I believe, in the latest ACI presented data presented at ACI the other year, was in excess of 85%. I think it was up to 88% if I'm not wrong. So that's remarkable. And I think when our North American cousins hear us say this, they just assume that we're not doing complex things radially, and that's not true. We actually do really quite complex. I mean, I did a multi-vessel case just radially the other day, in which happily did the whole case using a 6 French catheter, and we were using advanced atherectomy devices in order to be able to get a good result. So these things can actually be done. But the question in STEMI has been, which is the safest? And some of our older operators have often said that, look, just give me the chance to go infirmally and we'll just get the case done. And SAFARI actually showed that the difference wasn't as strong as we thought it was going to be. We thought this would be an easy win for radial. And in fact, this was less of a strong win. And I think there's a number of reasons that this happens. I think as we come through on our training and in our clinical practice, we get so used to doing radial cases that if you are presented with a case that has to be done femorally, you end up having to think twice. I think certainly I have to think very hard before doing femoral. And certainly when I was coming through at the beginning, I did femoral day in and day out. I'm sure I could do femoral punctures with my eyes closed. And now we've moved on to this era that we have to have so-called safe femoral. So you're angiographically identifying the markers. You're using an ultrasound to make the puncture. You may use a micropuncture kit. I don't have access to that in our hospital, but I know other people do. But I think what it does is, if you don't do femoral regularly, then your skills go down. And this has been shown in the matrix studies as well, that when you ask exclusively radial operators to make femoral puncture, I think femoral complications go up, bleeding complications go up. And this is why studies like SAFARI end up showing results that aren't quite what you expected.
Mm-hmm. And yes, it just belabors the point. Not to belabor it that much, but I think establishing a routine is critical in procedural fields. And if you have a routine, and if you've been doing cases, like you said, day in and day out, with a routine routine, there's a routine, there's a culture, there are ancillary support staff which get used to certain access. And then, how these patients are taken care of after the case is done is also very important. I mean, if you're systematically doing radial cases and not doing femoral cases, then, the staff that is handling complications, or, even, superficial bleeds or hematomas that may occur following femoral access may be difficult, leading to a hard endpoint like bleeding.
Oh, absolutely. We've seen this. I'm sure you've seen this in clinical practice. So studies are one thing, but real life clinical practices are completely other. And we've seen we get de-skilled in using compression devices. The staff get de-skilled in using compression devices, and every so often you will get a retroperitoneal bleed, and people, whereas in the past, people were very geared up for A, identifying it, B, getting it treated. This may now get missed because it's just something that's a little bit unexpected now. So I think the key thing is your comment that you have to be familiar with what you're doing and you have to do it a lot to a high quality. I think that's absolutely right. And I think the take home that I came away from SAFARI was actually sometimes we can get a little bit passionate about, for example, everything should be radial or everything should be one way or the other. But I think what this shows us is that there is room for both technologies. And for operators, for example, who are very happy and very safe with a femoral approach, can certainly go with a femoral approach rather than making it difficult for them. Because ultimately what we want is a good outcome for the patient. And if you can achieve that access safely, femorally, by using the ultrasound, by using angiographic markers, then I don't think that's such a bad thing. And we also have to remember the era has changed. You know, we're no longer using GPI, GP2/3A antagonists, and we're back to principally using heparin now. In the UK, we've certainly stopped using bivalirudin. And so perhaps some of the initial bleeding benefit that came from radial perhaps may be nullified as a consequence of that. So I love radial. I love it when the patients get up and just walk out the cath lab. I think that's absolutely fantastic. But you know, if for those operators who feel they can't do it or they feel they need to go with the femoral route, I think we mustn't penalize them. And so I think that's an important factor.
Yes, I agree with you. I mean, you know, listen, I think most of what you've just said, you know, resonates with a lot of the practice patterns that I've seen in the US. Bivalirudin, I don't use routinely at all. You know, most of the cases are on ticagrelor, heparin, and radial access. And, you know, like you've said, bleeding is minimal. I'm also, you know, again, you know, trained in the era where, you know, was very comfortable with, you know, both femoral and radial access. So I would say about 80% of what I do is radial, but then there would be 20 to 25% cases where we have to go femoral. For example, patients with bypass grafts, you know, even though, you know, we've gone left radial and that's worked fine. You know, there are some complex anatomies where you have to, you know, just do it femorally.
Yeah, I agree. And, you know, I've you know, just as a little amusing situation, every time I go left radial, I ask the staff to remind me never to go left radial. And I know there are people who swear by left radial and they feel that obviously I haven't got the ergonomics right, but particularly in bigger patients, leaning across these patients, trying to get grafts where you don't know the anatomy, just makes a slightly miserable experience. Whereas, you know, if you can do it femorally, I think that's fine. And of course, there are those patients with complex anatomy where you need large bore catheters. I think there is still a room for it.
I agree. So let's move on and talk about COAPT, which was, you know, taking patients to the cath lab following an episode of cardiac arrest, resuscitated cardiac arrest.
Yeah. So this was an interesting study because for me, I've always had, so the concept is, does every cardiac arrest need to go to the cath lab? And you know, do we have to take them, if they've been resuscitated, take them straight to lab and have essentially an assessment of the coronary arteries and maybe some primary angioplasty, or can we wait? And there are several schools of thoughts on this. So my personal school of thought was that if the patient had done the decent thing and managed to survive a cardiac arrest, then at least I could do was take them to the cath lab. But what this study has essentially showed was that we can afford to wait. And I think the reason that this occurs is that lots of patients who've had cardiac arrest have bad outcomes. And the problem we're taking them to the cath lab immediately is that we can make things a little bit worse. We give powerful antiplatelets, we give heparin, and if there's brain swelling after a period of downtime, then actually we can be making things harmful. And so that's an important factor. So if by waiting you mitigate that, you reduce that risk, I think that's a safe thing for the patient. And I think the other aspect of it is that naturally, and this is perhaps people don't talk about it, is that you will naturally lose patients in that very first hot period, in the first, say, 12 hours after the cardiac arrest. And so you are essentially only taking the survivors to the cath lab. Now, this is difficult. This is a highly emotive subject, and it's a difficult process. But what I took away from the COAPT study is that perhaps we don't necessarily need to be activating the cath lab for every single cardiac arrest patient. Now, that's not to say that patients without persistent ST elevation on their ECG, or those patients that had chest pain before the cardiac arrest, I think those patients are probably still will take. And so you must individualize care. But the finding was that there wasn't much value by immediately taking patients to lab. And, you will often find disease, but perhaps you're not necessarily going to be able to make it anything better in that first high risk period.
I agree. I think so. My practice has been, if it's a resuscitated refib or ventricular tachyarrhythmia or ventricular tachycardia arrest, and following resuscitation, the EKG or the ECG, the 12-lead electrocardiogram, is showing ST elevation. I mean, that patient obviously needs to go. In patients where ST elevation is not as prominent, or there's suspicion, again, to your point of individualizing care and diving more into the story. And granted, many times it's very difficult to get the exact scenario that led to cardiac arrest. I think you really have to sort of, talk to family members and sort of figure out how this particular patient was doing, before this unfortunate event occurred, and, make a decision. Also look at the other biochemical parameters like, lactic acid and evidence for leukocytosis and, hemoglobin. All these factors would increase the risk of a bad outcome in the cath lab. That's what I do personally.
Yeah, I would agree. And I think certainly this study was important for me because it meant that I was much more relaxed about these patients. I think I had a very aggressive approach of taking these patients to lab. I think I'd personally seen some cases in which I felt that I'd made a difference by taking them to lab. But now, certainly, those that have STEMI are definitely going to go there. And those that don't have clear ECG changes, I perhaps would wait. I think the presence of ST depression or any other alarming arrhythmia or any other alarming ST change, I would definitely consider. But I think it just helps risk stratify these patients. And I think in the era of interventional cardiologists having public reporting, this is an important factor. I think in the UK, we've had public reporting for some time. Arrested patients are treated differently because they stratify the data according to the clinical status of the patient. But and so that's why I've always felt we should take these patients because it gives them an opportunity. But perhaps these data basically tell us that we can relax a little.
I agree with you, completely do. So moving on to ESC, the European Society of Cardiology Congress, which, I think was, the marquee event for cardiology. A lot of good data coming out, arguably one of the best meetings for 2019. Would you agree?
I would agree. It was an amazing meeting to go to. I had the privilege of being there. And first, it's always amazing being in Paris. And it's always a great pleasure to be there. It's such a beautiful city. The conference venue was good. I think some of the European conference venues are not as well placed as the North Americans, principally because, as you say, they've grown organically rather than purpose-built. But the data was just incredible, and the atmosphere was electric. Biggest meeting in cardiology now, much bigger than the North American meetings. I believe it was 36,000 people attended. Registered attendees. That's not including all the other support staff and industry there. So just a huge number of people and some great data as well.
Yes, so Paris, has always been one of my favorite cities. It's is always a romantic place to visit, and it's certainly good fodder for the poet in me. But talking about the data that came out at ESC, so let's start with DAPA-HF, which I think is a landmark trial.
Yeah. So, I mean, it was controversial that it was presented at ESC at all, because as you'll know, it was originally aimed to be presented solely at AHA, but they managed to sneak it in as a ultra late breaking study because they were just so overwhelmed by how positive the data was. And I think the SGLT2 story is super important and will alter the way we treat patients going forward. So type 2 diabetics who don't have optimal blood sugar control, who are on metformin, and who have predominantly atherosclerotic disease are now recommended to have an SGLT2 as the next agent that's added. So that's over and above GLP-1s and any other agents, so better than gliclazide and all these things. And what the 3 SGLT2 studies showed, and that's true for EMPA, CANA, and DAPA, they all basically showed that there was a reduction in heart failure-related events. And so what DAPA-HF did was actually take patients with reduced systolic function, so heart failure with reduced ejection fraction, and randomize them to having DAPA or placebo. And they showed a really quite profound 25% reduction in the hazard ratio in the combined endpoint. So the combined endpoint was a combination of a couple of things. So there was cardiovascular death, and then there was hospitalization for heart failure. And then they had something which was perhaps slightly softer, which was urgent heart failure visitation or urgent visit for heart failure overall. And although you can kind of argue over the value of these kind of slightly softer endpoints, I think they are important because for our patients, having to come into hospital because of breathlessness or pulmonary edema is a frightening experience, and it's hugely costly. Patients are often in for quite a long period of time, and there is a huge amount of risk because they're going to get IV Lasix and have potentially hypokalemia as a consequence, and arrhythmia, and all these kind of things can happen. So anything that reduces that, I think, is a valuable thing. And then what they found was this huge reduction. But what was really quite profound, and they showed this at the ESC, but they really went into it in detail at AHA, was that the same benefit that was seen in the overall cohort was seen in both diabetics and non-diabetics. So that's a really quite profound and astounding finding. So the overall learning from these studies are that we can add these drugs as a heart failure drug. We've still got to understand exactly how they're having benefit. And I know there's active research into seeing how well these drugs work in patients with heart failure with preserved ejection fraction. But I can imagine that this is a very exciting time for heart failure doctors as well as heart failure patients, because suddenly we've got something that can make a real profound difference for their care.
Yes. So let me ask you a question. And, I was at a meeting recently, and I was listening to an endocrinologist who's, she does endocrinology clinic at the Cleveland Clinic. And, I was asking her as to whether she has seen an increase in consults from cardiologists or from heart failure cardiologists who now want their patients to be on dapagliflozin. I know you sort of mentioned that there was a class effect with empagliflozin and with canagliflozin, but, DAPA-HF was done with dapagliflozin.
Yeah, that's right. So DAPA's got the data at the moment, and I know that empagliflozin has a study that's going to probably complete and report next year. We in the UK have been quite forward thinking about this, and we've been running clinics in here where some of our post-PCI patients and those patients who are coming up to a year when we're typically advising on whether they go for long dual antiplatelet therapy or whether they stop, we have been recommending in our diabetic patients for the primary care physician to be starting drugs like DAPA or EMPA. And now in our heart failure cohort, we will almost certainly start increasing these drugs. I think it's important for cardiologists to be familiar with how to start the drugs and to understand the potential side effects and when they should recommend patients to stop. And there is a subtlety with this. So what I've found when I've personally been using these drugs is that, for example, you may need slightly less furosemide or Lasix. And you have to remind patients to have sick day rules. So if they're unwell, particularly if they're diabetic, then they may wish to avoid drugs that can cause hypoglycemia. If they're on insulin, they must never stop. There are some other potential side effects from these drugs. Urinary tract infections and genital infections, and typically in the form of thrush, are incredibly common. And I think if you've got patients who're having multiple thrush infections that are resistant to treatment, that may be an indication for stopping these drugs. And although I can imagine that many cardiologists will be very reluctant to become familiar with these drugs, I think that the benefit that we've seen in them is so strong that we should certainly consider them. And if you're not confident, then speak to an endocrinologist. We've got a good relationship with endocrinology, and in fact, we had one of our clinical lecturers in endocrinology come and give our department a talk very recently, and so we could all become very familiar with them. And the data is so strong that we should definitely be thinking about these drugs.
I agree with you. I think, again, I mean, I'm sure as an interventional cardiologist, it could be challenging to deal with vaginal candidiasis or thrush in a clinic patient.
Oh, for sure. Yeah. I'm not suggesting that we're the ones having to manage it, but the point is that particularly in a heart failure cohort, whether it's going to be you or your advanced nurse practitioner who specializes in heart failure, we have those here in the UK, they are going to have to see these patients frequently, and patients are going to report them. So we need to upskill a little bit in this area.
I agree. So, I mean, is your typical cornerstone therapy now for a heart failure patient with reduced ejection fraction at least, is a combination of a beta blocker, an angiotensin-neprilysin inhibitor, and an SGLT2? I mean, is that the modern cornerstone that we're going to see?
Yeah, it's hard to know when to add these drugs in, principally because the patients in DAPA-HF were incredibly well treated. Almost every single patient was on either an ACE, ARB, or sacubitril valsartan combination. So they were incredibly well treated in that regard. Virtually every single patient had a beta blocker, but there were very high levels of mineralocorticoid receptor antagonist use as well, so spironolactone or implerenone. And it means that this may be a drug that's added in after that point. So I can imagine, particularly when the payers start to look at this, because these drugs aren't going to be cheap, they may say, look, only once you've got patients on spironolactone, then you should be giving these drugs. I think the question is whether we should be giving them for stable patients who are in New York classification 1, or whether we should wait until they're in class 2, class 3. And then that's a tricky one, because the whole point is to prevent this slippery slope for our heart failure patients. So I would be inclined to try and give the drugs as upstream as possible. And I'd be interested to see how the heart failure doctors resolve this and how their guidelines change. My clinics are very broad in general. I have specialist clinics, but I also have a very unselected clinic. And so we end up looking after these heart failure patients. And we work in tandem with other specialists and advanced heart failure doctors, but they particularly want to work predominantly with advanced heart failure and those who are going to need more complex devices and therapies. And so the more general patient I'm just going to see in my clinic, as I'm sure you will too. And so knowing when to initiate these drugs is going to be super important.
Yeah, I couldn't agree with you more. So moving on from SGLT2 to actually talking about de-escalating therapy in our patients, and that is patients post-PCI who are on dual antiplatelet therapy. THEMIS was presented at ESC, and then I think I'm going to probably also have you talk about a couple other studies which are relevant to the topic. And those are ISAR-REACT 5, and then TWILIGHT, which was presented at TCT.
Yeah, that's right. So the world of antiplatelets gets really tricky and confusing. I ended up developing a bit of a reputation in my local hospital as being the antiplatelet guy. But I have to say, when I'm reading these studies, it becomes bewildering and to know how to reconcile the differences between them. So I think the key thing is that most people want to shorten DAPT, and they want to do it safely. So you need to balance the slight trade-off with increased ischemic events with the improvement in bleeding events. And THEMIS is the last of the ticagrelor studies that was done as part of this very comprehensive set of studies looking at extending the indications for ticagrelor in patients with stable disease, peripheral vascular disease, cerebral vascular disease. And what THEMIS was looking at was patients with type 2 diabetes and confirmed coronary disease. So either they've had stents, they've had bypass, or they've had at least a 50% stenosis on coronary angiography. And they were giving them ticagrelor or Brilinta, as you would know it in the US, and looking to see if it improved major adverse cardiovascular events. And there was indeed a benefit, but that benefit was relatively small and was unfortunately balanced out by an increase in bleeding events. And so the absolute risk benefit was modest, and although statistically very strong, but there is a significant increase in bleeding. And so this then becomes a situation where we start needing complex risk scores to telling us whether a drug is going to be of value in particular patients. And it also requires us to have quite complex conversations with patients, because drugs like ticagrelor, whilst excellent, they have a number of downsides. They do cause breathlessness in patients, and there is a high discontinuation rate. So this is an important factor. So just looking at the numbers, the placebo arm had an event rate of 7.6, and the ticagrelor arm had an event rate of 6.9. So the hazard ratio was 0.9, statistically significant at 0.038. So meets the level of significance, and this is for cardiovascular death, MI, or stroke. So relatively important events, but the confidence intervals are really quite close to unity. They go from 0.81 to 0.99, and bleeding events do also increase. And so we really have to worry about that a little bit. So we see a doubling in TIMI major bleeding, and that's not a small bleed. That's a major bleed. And even if we look at the various BARC scores, we're still seeing a big increase. So BARC 5, 4, or 3, we're seeing 2.5 times higher levels of bleeding. So we have to understand which patients can tolerate these drugs and which don't. And that's another challenge. When you've got big studies like THEMIS, I think they have enough data to be able to look at this in greater detail. I did ask Deepak Bhatt actually whilst at TCT whether they had the angiographic data in these patients to see if we could start teasing out the importance, whether the anatomy was a factor. But unfortunately, because of the sheer cost of getting the angiograms, they said that they didn't actually have that data. So that's slightly disappointing, but the results are what they are. It shows that there is a modest benefit, but at the cost of bleeding.
Yeah, so I mean, in your clinical practice, I mean, again, talking about individualizing care for patients, do you have a particular tool that you use to reconcile all the data and knowledge that we've garnered from these trials, these very expensive trials?
Yeah, it's really tricky, because I think there's a combination of the fact that scores like the DAPT score and the precise DAPT score, they give you pointers, but they will never tell you for the precise patient that's in front of you. And I think as an interventionist, we're often very driven by the coronary anatomy. And so when we performed complex bifurcation, or particularly a very proximal stents that are bifurcating into left main, I think we have a natural tendency to want to run the antiplatelets for longer, but that comes with a bleeding risk. And I think some of the risk scores don't include the coronary anatomy in that way, but principally because the study data didn't really allow it. So we don't have a great way of making this estimate. I know if you follow the great Bobby Ye, and they've really worked incredibly hard at making the risk scores and intuitive tools, but certainly this is not in my practice. And I would say that most of my colleagues at our particular hospital aren't following this. I think perhaps others in the UK may, but I'd say that I'm not sure about the precise external validity of some of these scores, particularly in some of the patients we end up treating. We have a very cosmopolitan, very mixed cohort of patients, which simply wouldn't have been in some of the North American studies. How about yourself? Do you use any particular risk score or calculator?
Yeah, so, talking about Bobby, I obviously know him. I was fortunate enough to have trained with him when he just joined the Beth Israel Deaconess from Mass General when I was a fellow at BI Deaconess. So I do actually use the tool that he's developed, the DAPT score. And then there's another tool which is more simplistic. It's the precise DAPT, which I think, Deepak Bhatt and Greg Stone were authors on that manuscript, which was published in Lancet.
Yes.
So those are the ones that I sort of go to when I have to make a decision on stopping versus starting, or escalating versus de-escalating therapies. But again, I think it's become, like you said, it's becoming confusing as more data are coming out from all these trials. And we're going to talk about TWILIGHT in a little bit, which is
absolutely.
Which patients to do the monotherapy with aspirin versus an advanced P2Y12. So why don't you talk to us a little bit about that? Yeah.
So TWILIGHT is very interesting because it takes the opposite tact. So rather than adding in a potent antiplatelet, it's actually removing the stalwart of aspirin. And so this study that was led by Roxana Moran, performed internationally with a great number of high-profile investigators, basically took patients that were high risk and that had coronary intervention, and then at 3 months they were then randomized to remain on aspirin or to go to placebo therapy and continue on ticagrelor alone as a single antiplatelet. And what they saw was benefit in this cohort. And what's interesting is they not only did they see a reduction in bleeding events, but there was also a reduction in ischemic events, which is somewhat unusual because you're essentially eliminating one of the antiplatelets. And there are some complex pharmacology behind this, and this overall feeling that perhaps there is an interaction between aspirin and ticagrelor that may be to blame for this. And in the original Plato study, the feeling was with very high doses of aspirin, then there is an interaction with ticagrelor. And but I think that we've moved away from using high dose aspirin since that time. Certainly never been the practice in Europe in that regard, but perhaps the American cohorts are now used to using lower dose aspirin. So it's interesting to see this phenomena where you have a safety signal, you're getting less bleeding, but also an ischemic signal. And where the ischemic signal was strongest in the patients with the most complex coronary anatomy. So those patients, you can intuitively imagine that if they have super high risk, they've got complex coronary anatomy, that they will then get the most benefit too.
Yes. So let me ask you this question: Are you comfortable in stopping aspirin in someone who you've stented post an acute coronary syndrome? What is your strategy in those patients?
Yeah, so that's a tricky cohort. I have to say, I intuitively would be concerned about stopping aspirin. We do naturally stop the aspirin in those patients who are on so-called triple therapy. They've got concomitant atrial fibrillation, and so they're on a NOAC. We typically use either rivaroxaban. Now, after Augustus, we may also use apixaban. And we get rid of the aspirin typically at 3 months. There is some data that shows there is early hazard when you remove the aspirin very early. There's some papers published recently showing that there is an increase in stent thrombosis during that period. And so therefore, allowing the patient to take aspirin for probably about 3 months would be sensible in that cohort. We don't have that precise data in all comer ACS in sinus rhythm. And so it does make me nervous of getting rid of the aspirin. However, I think aspirin is the one that causes GI bleeding. Aspirin is the one that causes allergy. Aspirin can cause lots of other side effects, and so we have to although we've grown up with this drug and this is the stalwart of cardiology, there are some downsides to the medication, and so we should look very carefully at the data, look carefully at our patient, and then try and make our best guess. But there isn't a single study that answers all of it in one go. Unfortunately, there's nuances for every single one.
I agree with you. You brought up a very interesting point of aspirin allergy. I've actually had a couple patients, fairly successively who both had aspirin allergy, and they both ended up getting, primary PCI, and I was the operator doing it, and tried to desensitize them, and it became a nuisance more than, the process of desensitization. And, in those patients, what we did was to just add the stable 2.5 dose of rivaroxaban.
Yes.
Both these patients were in sinus rhythm, were getting ticagrelor, or were allergic to aspirin. So that's been my strategy. I don't know how evidence-based that is. But,
This is what we're doing too. And so I would hasten to add that the number of patients on low dose rivaroxaban, or as I call it, baby dose rivaroxaban 2.5 BD, and ticagrelor are very modest in the studies, very, very modest numbers of patients. So there isn't a huge amount of data, but that's what we've done in our aspirin sensitive patients. I think the first thing to say is true aspirin allergy is actually not that common. I think a lot of people who say they're allergic to aspirin aren't. And so it's trying to take a history from the patient, trying to understand why they think that they're aspirin allergic. And then if they are genuinely, we have at Imperial, St. Mary's Hospital, we've got a very dynamic and engaged allergy unit, and we can ask them to perform desensitization. There are some very simple protocols that you can perform on the ward, but in general, we've now moved over to using a potent P2Y12 together with rivaroxaban, just in the same way as you have.
Yeah, that's good to know. It's reassuring because you're sort of stuck between a rock and a hard place, with these patients with a fresh stent, and it's sort of almost a day. I shouldn't really say a data-free zone, but like you said, data are very limited.
Yeah, I mean the global leaders used aspirin for a very short time after ACS, but overall global leaders was a neutral study, and so it's hard to basically take too much away from that.
Yes. So let's while we are still on antiplatelets, I think we should finish it up by talking a little bit about ISAR-REACT 5.
Oh yes, yeah. So ISAR-REACT is it made some people very, very happy. So the background to this is so I don't know quite what happened in the US, but certainly in the UK, there was a period where everybody was using clopidogrel for acute coronary syndromes and STEMI, and then prasugrel came along, and then ticagrelor came along very shortly after, and then there was a confusing time where we were using potentially all three drugs for acute coronary syndrome patients. But the data for ticagrelor seemed to be a little bit stronger, and there's some debate over that, about exactly where its strength lays, and there's some novel analyses out there. And it basically meant that in the UK, we settled on ticagrelor as a principal agent for acute coronary syndromes, particularly in STEMI, and then it rolled out to NSTEMI, and now it's used in all forms of acute coronary syndromes. But prasugrel has recently gone off patent. It's now very cheap in the UK, and it's in some places in England, there are some staunch prasugrel fans. Now, prasugrel is a great drug. It's basically like clopidogrel, except it's already had a degree of hydrolysis and cleavage within the liver, and therefore it's already one step of closer to activation than clopidogrel is. So it's more rapid onset. It is more potent, and it achieves a great antiplatelet effect. But it ran into some trouble because the original ticagrelor pivotal studies gave prasugrel after the coronary anatomy was known. And this is very different from our usual practice, certainly in the UK, where, for example, if you've had an acute coronary syndrome with a small troponin rise, it's not common for patients to go to cath lab the same day. They may wait a couple of days. The typical level of waiting is 1 to 2 days, and we've got a number of metrics that you want to get the case done within 3 days, certainly. I know that sounds a little bit unusual in the US, where it's counted in hours, but we would therefore want to give an antiplatelet up front. So the problem with prasugrel in the UK then is if you're not going to take the patient to the lab straight away, then you can't give drugs like prasugrel. So where ISAR-REACT did was they took patients who were having STEMI, and they randomized them to ticagrelor or to prasugrel, and they basically were under the impression that ticagrelor was going to be better. they actually found the complete opposite. They found that prasugrel had a much lower event rate than ticagrelor, and there was also a much lower bleeding. There are some complexities here. One of the main complexities is that this isn't really a pure antiplatelet study. This is also a strategy study, because if you were randomized to go down the route of prasugrel, then you didn't get the drug until after the anatomy was known. And therefore, you would potentially have less bleeding and bleeding complications because the patient had less antiplatelets on board. So that's one potential limitation of the study. The second is that there was a very high femoral rate in this study, and although it's multi-center, it's predominantly performed in Germany, and for whatever reason, the femoral route is very common there. And so you could argue that that may have driven some bleeding events. And so whilst we're very delighted to see that prasugrel came out so strongly in this study, because this is now a cheap and readily available drug, better for our payers and better for our patients, it does mean that there are some limitations in the way we interpret it. And furthermore, I think those in the antiplatelet field have recognized that the likelihood of getting a comprehensive answer has always been low, mainly because we didn't think pharma would pay for it. They're not likely to do the study. And the other reality is that you need something like a 14 or 15,000 patient study as a minimum to be able to compare this. And ISAR-REACT is a good study, but it's only in about 4,000 patients. So it's perhaps not truly big enough to be able to answer the question definitively, although it certainly appears to be a good study, and it should help give confidence for those patients, those centers and clinicians who are preferring to use prasugrel.
Yes, I agree. I mean, I think, what you described with the practice patterns between prasugrel and ticagrelor are very similar to what we've encountered here in the US. Ticagrelor came out as a winner because, the data were better. There was a mortality benefit. And I think it was without all the contraindications that prasugrel came with, right? I mean,
So prasugrel had some post-hoc analyses that showed that the bleeding rates were higher in low-weight people, patients over 75, patients with prior stroke. So that's a huge factor. But we have to remember is the original prasugrel studies didn't know that, so they included all those patients, and that's probably what drove poorer outcomes, so higher bleeding rates. And so that's why they created those contraindications for the drug. And so now if we were to do a study where we select out those patients who meet those contraindications, then naturally you're going to drive a lower bleeding rate. So it's perhaps academically slightly less pure, practically very good, because that's exactly how you're going to use a drug. But you could argue that, if you're wanting to understand which antiplatelet is the best, it does muddy the waters slightly.
Yes, I agree with you. And, I think the advantage of prasugrel is obviously it's a once-a-day drug compared with ticagrelor, which is
for sure
a twice-a-day drug. And
yeah, for sure. I think that's one thing that we've learnt over the years is that compliance of most medications is poor. Compliance of BD drugs is particularly poor. And if you look at patients who get dosette boxes, those pre-packaged containers that have the medications all lined up, then even in those patients who have a clear prompt of what they need to take when, that the uptake of the second dose of the drug is actually quite bad. And so anything that moves away from that is going to be beneficial.
I agree. So let's move over to revascularization. I mean, that's what we do day in and day out as interventionists.
Yeah.
So let's talk about COMPLETE, and then let's talk about EXCEL.
So COMPLETE's an excellent study. So COMPLETE, the concept of COMPLETE is a question that keeps coming up time and time again. So when we do STEMIs, as all interventionists will recognize that when you do STEMIs, lots of patients have more coronary disease than was expected. And we don't know quite what to do with those other lesions. And there's been studies that have pointed in lots of different directions. One of the big studies that came out back in 2013, all those many moons ago, was a PRAMI study. It's a study performed in the UK, but had a number of limitations. It was relatively small, about 400 patients or so. And it took many years to recruit. I think it took about 5 years to recruit. And so there's probably a huge selection bias. But what they showed in that particular study was if you stent all the coronary stenoses that there seemed to be an improvement of events. Now, the majority of the events it reduced was repeat revascularization. And so we should always be careful in that, because, of course, if you've stented all the disease, then there isn't any more disease to stent. And so patients aren't going to come back for more stenting. So I think you should always take that with a slight pinch of salt when we look at any of these studies. And so that kind of gave us this idea that we should be managing the multivessel disease in a different way. And then there was the DYNAMI studies and Compare Acute, which used fractional flow reserve, or FFR, to try and guide our management of this residual disease. And both of those studies had similar findings. So if you did like DYNAMI did, which you did FFR during the same admission, or Compare Acute, which was done at the time of the STEMI, they all basically reduced events, but actually there was no reduction in death or significant MI. There's only reduction in repeat revascularization. So with that kind of context, the McMaster group really wanted to answer this more definitively, and they organized a much larger study called the Cobra Study. And what they did was they took about 4,000 patients who had had successful PCI to the culprit during primary angioplasty, and then randomized them to either complete revasc or culprit-only revasc, and then follow them for 3 years. And it's a modern study, it's performed in the modern era, and so we've got the latest generation stents and the latest imaging techniques. And what's quite profound is in the complete revasc arm, there was a very high revascularization achieved, more than 90%, and a syntax score of incredibly low, so 0%, a score of 0. So that kind of tells me that the patients that are included in the study are perhaps not super complex, not super high risk. So I think that's an important factor. And the other thing to say is that the lesions that were included in this study by angiographic assessment, and we know that's very limited, QCA we know has limited reliability, was generally very severe. So they were all, on the whole, more than 70% by QCA. So the lesions were not mild or moderate lesions, these are severe lesions. And although the headline, and if you read the abstract, they'll say, oh, they used FFR, the actual reality is, if you look at the supplementary data and you look at do a deep dive into the data, actually FFR was performed in very trivial number of cases, according to the graphics I've seen. And so it was only performed if your stenosis was between 50 and 70%. And so that accounted for less than 1% of the patients. So a very small number of patients actually had fractional flow reserve. So this was predominantly angiographic revascularization. And what they showed was in a cohort of patients that were followed, that the time to that first cardiovascular death or new MI was significantly separated by quite early on. You start seeing a separation in the first year alone, and then it widens out at 3 years and at 5 years. And we see a hazard ratio of 0.74 in favor of complete revascularization, and it was highly significant. And if you start including repeat revascularization, then obviously the outcome becomes even stronger. But as I say, that's potentially a biased endpoint. I think if you follow cardio Twitter and you see these things, I think there are two camps. There are those that think that this study is amazing and that we should believe it wholeheartedly, and those that say, well, actually all you're doing is swapping periprocedural troponin rise with other type of MI. I don't think that's actually true. If you look at the data very closely, there are a significant reduction in STEMI patients, and that's got to be a good thing. If you look at the data very clearly, the type of MIs that we see that are being prevented are mostly type 1 MI, so true MI with plaque rupture, and there is a big number of NSTEMIs, and I'd say an NSTEMI is important because it leads to hospitalization, increased cost, and STEMI, which is life-threatening. So there is a reduction there. So I'm not a naysayer. I think this is true. I think this is an interesting study because it goes back to what we learned in PRAMI. And PRAMI had a lot of limitations, but this study basically tells us that if you present with an acute coronary syndrome, if you present with a STEMI, then you have probably multiple areas of plaque rupture. And whilst on the whole, we fix that by giving antiplatelets, potent antiplatelets, that actually, if we perform revascularization, we probably reduce events as well. Now, that will obviously come with the risk of periprocedural events, and increased cost and increased cath lab usage. But if you roll this out internationally, if you're reducing STEMI events, then that's going to potentially be a useful factor. So I think I'm in the camp that says COMPLETE is a good study and is certainly helpful. And there are variable opinions on this, but I'll be interested to see what you think.
Yeah, so thank you for a great summary. So I have a question, and then I'm going to share with you what we've been doing at our institution. But what is the proposed timing of revascularization? I mean, STEMIs. I mean, not all STEMIs are the same. You and I know that. I mean, there are STEMIs
Yes.
which you're done within 30 minutes, and then there are STEMIs which you're struggling for 3 hours, and that there's no reflow,
Yes.
or there's complex anatomy.
Yes, for sure.
And obviously these decisions need to be individualized, like we've said, for all the therapies that we've discussed here. But when is the typical timing for you to intervene?
So the study data tells us that actually, as long as you intervene within a sensible period of time, and I think they allowed 45 days, which is fairly generous. I think they found there was no real difference of whether you did it immediately, whether you did it during the index admission, or up to 45 days later. So that gives us a breathing room and says, look, we can allow the patient to go home, we can allow the patient to recover. I think it's important to allow the infarcted territory to recover, because what you don't want to do, say, for example, you've got a prox LAD STEMI, it's been a large troponin rise, there's been some cardiac impairment as a consequence. I think it would be a terrible shame for you to then potentially have a complication in the right coronary artery and therefore really render the myocardium at risk because two territories have had a hit. So if you can defer it for a short period of time, allow the drugs to work, I think that probably makes things better. And a lot of the STEMI patients, they're de novo presentations, they're not known to have coronary disease before. These patients typically haven't had angina before. Many of these patients, about half the patients, have never had angina. And so it's not like these other stenoses were immediately requiring revascularization. So you have a bit of breathing time, and then you can get high intensity statins in. That seems to make a difference to the angioplasty and the plaque that's there, and perhaps can make your subsequent repeat PCI easier to perform. But of course, the reality is you have to individualize care, because there is no one size fits all in this situation. I think if you've had a very straightforward STEMI, I think you've doing an OM vessel, for example, that was occluded, and you've opened, and you've got a stenosis in a mid LAD or a distal LAD or something like that, then why burden the patient to have to come back in and have a second procedure? And you feel that you can safely perform it, then I think that's reasonable. But what we typically have before we do our STEMI cases is we have access to echo. We all carry our own little echo machines, portable handheld echoes. Plus we have echo machines in the cath lab, so we will image the ventricle as the patient's going onto the table, and so get a good idea of what LV function is. And if the LV function is good, then I think you've got time to play for opening up any other vessels. If LV function is looking less good, then you might want to wait.
Yeah, it's fair. It's very similar, actually. It's very similar to what we do. We usually stage the residual lesion, and we would try and do it during the same hospitalization if the LV function is normal, and there's wall motion in the area of the culprit, which is not a surprise. We'd rather just get the patient back and take care of it before the patient leaves the hospital. At times we would just do it in the same sitting if the STEMI has gone by very quickly, and you have the guide catheter up and you have the wire up, and all you have to do is just swap the wire and put it in the next vessel. We've done that, and that's gone well. But then there are other STEMIs where the shock is imminent and impending, and you've just revascularized the proximal LAD, and you've just
get out and
decent
get the drugs working. Yeah, absolutely.
Yeah, completely agree. So let's talk about Excel now. The 5-year data which was presented at TCT, and there's a huge Twitter controversy on it.
Yeah, I mean, this got a little bit out of hand, I felt, and I feel sorry for Greg Stone, who who was, he's a prominent investigator, and he was getting hounded by some people on Twitter, which perhaps was really uncalled for and perhaps unfortunate. So I think many of the readers or the listeners will know. So Excel was a randomized study looking at patients with left main stem disease and randomizing them to intervention with a Zients drug-eluting stent or to traditional bypass surgery. And they looked at composite of death, stroke, and myocardial infarction. And the primary outcome was powered for a 3-year outcome. And at 3 years, there was actually no significant difference. And then what we find is, as you go out to 5 years, that there is a swapping of the curves, and that there is a higher event rate in the PCI arm, such that the primary endpoint happens in 22% of people, and the bypass event rate is somewhat lower at 19%. And so there is a clear 3-point absolute risk difference in favor of bypass surgery. And I think this is something that we are honest about, and we say, look, there is a benefit for bypass surgery, and there's no doubt about that. But I think some of it comes from the way that perhaps the paper was written, and there is a particular style that New England Journal requires, and the phraseology. And I think Professor Stone has been absolutely fair. I mean, they use the terminology that the outcomes are similar. They're not saying they're the same. And statistically, they're not different. But of course, we recognise that there is a limit of power when you go out to 5 years. And what it happened was at a major surgical meeting, I believe it's called EACTS, an author and a collaborator and a member of the executive team, Professor Taggart, who's actually a British cardiothoracic surgeon who works in Oxford, who came out very strongly against the study and had announced that he had removed his name from the paper, and he's obviously on the original manuscripts, but has removed his name from the 5-year data. And this then triggered a number of people to really challenge Professor Stone and suggest that there'd been some kind of attempt to confuse or to alter the endpoints by perhaps changing the definitions of myocardial infarction. I think the difficulty comes whenever you're designing a study of you have to set a couple of endpoints, and trying to define how you're going to define myocardial infarction is an important factor. And the surgeons felt that the outcome had been designed to put them at a disadvantage, because we know that bypass surgery is typically associated with more troponin rise and CKMB rise, and therefore in that early stage you are going to get a higher event rate. But we also know that CABG is associated with a higher stroke rate. So, and that's been shown time and time again, and we saw that in this study. And we also know that PCI is limited because there will always be a higher revasc rate. So if you perform PCI, because there is a degree of stent failure, because you're doing it in the left main, if a patient ever presents with chest pain, then you're more likely to take the patient back to the cath lab. And as the Syntax and even the Syntax 2 study has shown, that operators have a tendency to so-called touch up the stents they've done, so they will naturally drive ischemia-driven revascularization in these cohorts of patients. So we understand that there are differences, but I think the overall findings of the study to say that in the modern era, with modern techniques and modern stents, that we can give patients an option. And this is not to say that this is the right option for all patients, and I refer many of my patients for bypass surgery. But I would also say that we get a lot of patients back from our surgeons. So if you have patients in their 80s, patients who've got complex comorbidities, that the surgeons are unhappy to take to theatre. And as a consequence, we have to perform PCI. And I would also say that there are, whilst the lemur is an excellent graft, vein grafts are generally not very good. And we often have patients who have had bypass surgery, sometimes I think perhaps too early in their journey. And then they come back to us in 5 years with really now complicated anatomy where vein grafts are closed, native vessels are closed, and we as interventionists are left with incredibly complex disease. And so perhaps if we can have a paradigm that we are trying to avoid bypass surgery as early as possible, and then perhaps consider bypass surgery later, and there must be a sweet spot where we can kind of give patients an opportunity to get life through without having their chest opened, and then perhaps have surgery at a later date, which will then ride them through for the rest of the year. I think we don't have the data to support that, but this is a kind of feeling that I've been coming to. So I think Excel was a good study. It's well performed. I think doing these studies are naturally very complicated. There is a huge degree of negativity over it. There is a clear separation of death. There is a higher death rate with PCI. And I think there's no doubt about that. We're not going to try and hide behind it. But I can say that for many of our patients, the ones that we end up performing left main PCI for, they are having it because that is the best option available for them, not because we're trying to avoid them having an operation or something along those lines.
Yes, I agree with you. I think it's unfortunate when it becomes a competition between the surgeons and the interventionists. It's never meant to be that. I mean, I think we're all here to take care of our patients. I think we all are passionate caregivers. We go to our places of work with the purpose of doing the best that we can for our patients. And I think as long as we remember that as we're stepping in either to the operating room or to the cath lab, I think it'll all be fair. And I completely agree with you that, we get a lot of patients back from our surgical colleagues actually, who are reluctant to take them to the operating room, and we end up revascularizing them percutaneously. And, the goal really is to deliver the best possible patient care.
Yeah, we need the surgeons, and they need us. I think we've all been in situations where patients have had early graft failure, and they need early revascularization percutaneously. And equally, we've had situations where the anatomy is so complicated and the risk of complex atherectomy may be too much. And we've got some stalwart surgeons who say, look, why are you going to break your back doing a complex PCI when we can do a straightforward bypass operation? Equally, I think for those who've ever worked at the Hammersmith or places like Harefield, will know that we have these meetings. We call them the JCC meetings, or their heart team meeting, where I would say that there is vigorous debate, shall we say, to put it politely, between interventional cardiologists and cardiac surgeons. And sometimes there can be genuine falling out between people. And I would say there's really no need for that. I think we're all drowning in coronary disease and patients coming in with acute coronary syndromes and ischemic events. I think there's enough work to go around. I think we should take the opportunity to try and foster a supportive environment for our surgical colleagues. And I think sometimes they feel within the TAVR era and where with PCI and people becoming so confident with PCI that they're going to perhaps be somewhat threatened. I think they should feel satisfied that they are going to do complex cases that need bypass surgery, and we are going to do cases appropriately. And I think that's as long as everyone feels comfortable, there won't be that falling out.
Yes, and let me ask you this in passing as we move on to AHA and wrapping the podcast, is how frequently do you in real world scenario, is it mostly just visually driven, and or is it very objective when it comes to scoring multivessel disease? And do you pull out the computer screen and do a syntax score, or
yes? So we were a syntax 2 site, and we definitely we work very closely with Javier Escaned, who's a major contributor to syntax, and Patrick Sorois has become an Imperial professor. And so we clearly do calculate the syntax score. I would say the majority of the time we are not calculating the syntax score using the formal methodology. Our process of revascularization is incredibly physiologically driven. Every patient will have had ischemia testing before they get to the cath lab. We then do on-table invasive physiology, and our surgeons expect it. And in patients we present at our heart team meetings without physiology, they ask us, why didn't we do it? And sometimes we say, look how severe it is. And they just turn around and say, well, didn't you tell us that you can't tell by the angiographic appearance, and they're absolutely right. So we do a lot of invasive physiology, and so this is the way we tend to practice. And so this means that if you look at the Ripcord study, if you look at the R3F study and the hilariously named ISIS study, I think this shows that if you start using physiology on a routine basis, you will alter your understanding of coronary disease. And I think you will realize that lots of patients who you think can have PCI actually need to go for bypass. And similarly, the patients who you think need bypass actually need just a straightforward PCI to a single vessel. And so I suspect that this is really one of the reasons that we don't end up matching or besting bypass surgery in a lot of the cases, because actually we're simply stenting either the wrong vessel or within the vessel the wrong stenosis. And I think interventional cardiologists, certainly from a previous era, perhaps were too proud to admit this, and this has led to this constant situation where our studies end up being negative. And I think we should be very careful as we go forward in how we do these studies, and to select our patients well, to make sure that we're targeting the right lesions using intracoronary physiology and imaging, and it all goes together. Not to say one is better than the other, but using the combination of the two to make sure we're selecting the right patients for revascularization.
Agree. Excellent summary. So I don't think we can end 2019 without talking about ischemia.
Yeah. Yeah, well, there is technically only one study in 2019, and that is the ischemia study. All other studies basically failed to exist afterwards. So, I mean, what are your thoughts on ischemia?
Listen, I think I think there was a Twitter storm about it, and it was all built up, and highly anticipated, obviously, for obvious reasons. So, my take on ischemia is as follows. I think if you were to think of how modern cardiology was being practiced, at least the way I was practicing it before ischemia results were presented, was, I think Orbita had significant role to play in it. Was, if patients come to the office and are otherwise very functional and have stable angina, and it was, they had a stress test. Most of the patients would have had a stress test anyways before they would come and see us.
Right. Is that a treadmill, an exercise test, or?
Yes, it's will mostly be a combination of an imaging and exercise. So for functional capacity, and they would either have an echo, most likely.
Okay.
So you could actually see, baseline left ventricular systolic function, and you would see the quote unquote area of myocardium at risk or percentage of ischemia.
Okay.
And then if it was, for example, inferior hyperkinesis, which was inducible, normal at rest, patient has stable angina, I would actually start that patient on, statin, aspirin, anti-anginal therapy, and discharge the patient from clinic with close follow-up in about 6 to 8 weeks, and see how that patient's doing on medications. And if, at that point, it would really become a shared decision-making process, whereby if the patient was like, I'm, and these, granted, these medications come with a lot of side effects. I mean, we may not realize that as prescribers, but patients hate taking beta blockers because it causes a lot of fatigue.
Yeah, for sure. I think I think you're absolutely right. So I mean, this is the thing. So the concept of ischemia is really a really good idea, and I think it's amazing that they were able to do this study. I think there are some caveats to it, and I think we're going to pick over this study over the next few months to years, and there'll be those that say, look, we told you so back in 2007, and Courage showed essentially this, and there'll be those that say, look, there are these flaws. So for the listeners, I think the principal idea was that you had to have stable angina, and then you had to have had an ischemia test that showed moderate or severe ischemia. And these were read by the individual recruiting centers and then overread by a core lab. And that's interesting in itself because that's a huge amount of work. And the idea was patients were randomized early, before coronary anatomy was known. Okay, so the reason they did this was to avoid this situation that once you see a stenosis, once a patient knows there's a stenosis, there is a problem. Okay, and we've seen this in multiple studies. And in Orbiter, we went through a very complex blinding algorithm in which the patient didn't know, operators weren't involved in follow-up, but the cath lab staff and the nursing staff weren't allowed to tell the patients, and they weren't given cath lab reports. Even the primary care physician wasn't told. So we went through a very complex process of blinding in order to be able to achieve that. So to try and get around this issue of once patients know about stenosis, it can cause problems. So in ischemia, they randomized after a CTCA had been performed. And the reason they included the CTCA is complicated. The reason was because there was concern that patients with left main stenosis would be missed. And some would say, look, a significant left main stenosis isn't going to be missed on stress testing of some kind. And I've actually seen lots of cases where that's not the case, where left main was missed by non-invasive testing. And so I think that's an important factor. They undertook CTCA, and then they randomized patients. And the randomization is actually to conservative therapy with medication, and then only for cath if there is a failure, so increased symptoms or unacceptable symptoms or becoming unstable, or an immediate invasive strategy. And I think this is where, for us in the UK, it becomes a little bit difficult, because the time it takes for a patient to be seen in clinic, be sent for an ischemia test, see the ischemic test, come back to have follow-up, have medication started, and then maybe decide for an invasive cath is long. It's really long under the National Health Service compared to in the US, where I suspect you'll be doing this within a matter of days. Mm-hmm. And so I would say the majority of, and perhaps there's a large number of patients recruited in India, where there is a thriving middle and upper class who seek healthcare and invasive options very early. And so I would say that the time from diagnosing ischemia to cath is short in many countries, whereas in the UK it's actually pretty long. So we already know that the majority of patients are absolutely fine before if they're having a long wait. We already know that. I think there is a concern around the world that if you've got severe ischemia on a functional test, then you've got to get to lab, otherwise these patients are high risk. And so that's the first thing I would say, that in the UK, we come at it slightly differently. Plus, you also have to remember in the UK that there is a great level of conservatism. I think in the US, I saw on Twitter, there is a drive for so-called conservative medicine. I think if our colleagues in the US who are espousing that came to the UK, they would appreciate that actually what we're practicing on the whole is already in keeping with that process. So what they then found was they follow these patients up, and if you follow them up for major events, what they found was no real difference out to 5 years. They found an interesting phenomena where there was an increase in early MI in the invasive cohort, which were likely to be peri-procedural infarctions. And then going out to 5 years, and the streams cross over around 3 year mark, we see an increase in MI in the conservative cohort. And but overall, it balances itself out, and there isn't a statistical value to the strategies being tested, so the invasive versus conservative. There's a couple of points, though, I think that are really important for people to understand. And I think this is super important for people to appreciate. This is being sold as a stenting study, and that's simply not true. The first thing to say is that if you look at the invasive cohort, so it's 2,500 patients, of those patients that went to the cath lab, that was in the so-called invasive arm, only 80% of them had revasc, okay, of any kind. 20% of these patients were completely deferred. And in that cohort, 66% of them, so 2/3, were deferred because their arteries were essentially unobstructed. So that means that this is a failure of both the ischemia testing and the CTCA, okay? Because CTCA was blinded, but the CTCA had suggested there was at least a 50% stenosis. And therefore, in a good number of patients, and I've done just kind of calculations of these, so this is around 350 patients, actually had normal vessels, and so didn't have any stents. And a 33% of the cohort that was deferred, so around 170 patients, actually had coronary disease that was too severe to be treated by any kind of technology. So they had no treatment. So that's important. And then in the so-called Revasc arm, there was only 1,500 patients that actually had PCI. and 538 patients that had bypass. So, and if you look at the numbers, it's the way they're presented. It's 74% of patients had PCI, 26% had CABG, and if you look at the total cohort of patients in the immediate invasive strategy arm, we're looking at around 60% having PCI and 21% having bypass. So this is not truly a stent study. I think that's the thing to take home. And you know that actually, if you look at the slide deck and you look at the DAPT arm and you look at how much DAPT usage there is, it peaks at around 60%. And it doesn't go to 90 or 100%. And I don't know of any interventionists who will be prepared to put drug-eluting stents in without giving DAPT. So that tells me that actually this is not a true revascularization study. So in fact, what this is, a way of looking at it is that this is a study of looking at the ischemia testing that gets patients in front of a cardiologist and then takes them into the cath lab. And this shows that actually there are limitations to this technology. There are a lot of patients who were screen failures that didn't have coronary disease. There are a lot of patients who were failed at the CTCA point who didn't have anything significant. So that tells us that actually a lot of the ischemia testing that's done is not that helpful. It's not that useful, and it perhaps isn't identifying the right thing. And so I think we should probably look at the type of ischemia testing that we do. And then we should also look at the number of patients that are in the conservative arm that end up having some form of revascularization and intervention. And that's not a trivial amount. So out to 5 years, it's bordering on around 30%. So that's quite a large number of patients. And I think that therefore will limit the power of the study to be able to find an answer to the question. But I think it's realistic, because I think if you manage patients medically, I think you can therefore say to a patient, not that you're going to have no events, not that you're going to be absolutely fine. You can say, look, at 5 years, there's a 30% chance that you'll end up having to have further revascularization or coming into the cath lab. But that also means there's a 70% chance that you won't. And so patients can then make a shared decision with you in how you're going to do it. So I look at ischemia in a slightly different way. I think it's looked at, the medical therapy arm guys are saying, look, this is the death of coronary intervention. The interventionists are looking at the MI rates. I'm not sure we can interpret a huge amount yet until the papers come out and we understand this stuff more deeply. But we can certainly say that when we treat patients with medicines, it's mostly safe in stable patients, particularly when they've had ischemia tested by current conventional means. So I think 25% of these patients just had exercise testing, and the others had nukes, which in the UK are not that common. We use a lot of stress echo and a lot of stress MRI. And we've got very good data to suggest that if you don't have ischemia on stress MRI, the patients do very well. And similarly with stress echo. And so I would say that, the meme is that cardiologists are saying that it's not going to change their practice because they're already practicing this way. I'd say in relatively conservative countries like the UK, where we are already less, stent-tastic than in some other countries, then it perhaps is already a little bit like what we're already doing. Whether this study gives credence to the CTCA pathway is less clear. I mean, it wasn't scientifically tested or designed for that. But certainly if you look at the data and say, well, CTCA certainly excludes a lot of patients, and it certainly stops you doing a lot of unnecessary caths, I think that is a positive finding. And I think we should now interpret CTCA in a different way. I think if you see a 50% stenosis, I think I won't worry about it. I won't send those patients off for functional test because I would say, well, the majority of these patients are fine. So I'm just going to give you medicines. I'm going to give you treatment with aspirin and a statin and potentially a beta blocker. And I'm going to follow you and see how you are. The difficulty we have that perhaps you guys don't have is that our payers will not pay for follow-up. And so many of these patients have to be discharged back to primary care. And our primary care physicians, our GPs, are under a huge amount of strain already. And there is a real crisis in the UK of staffing primary care. And so I'm not sure whether we can truly balance this issue out in the UK. I think those who say, oh, it's easy to give optimal medical therapy have perhaps not followed patients and tried getting it into them for a very long period of time. And, they will understand how difficult it is. As Rasha will tell you from the Orbiter study, where there was a very aggressive escalation of medical therapy, it can be quite tricky. Patients do get side effects. They do require lots of reassurance and manipulation of the doses. And so I think there is a situation where we can come away from this study where we think it's really helpful. I think it does change practice. It certainly slows down. We definitely don't need patients going to the cath lab within hours or days. I think you can take time. I think you can take time to up-titrate the medications. And you can reassure patients that they aren't going to have an adverse event in the form of death in the near term. I think that's super important. I think that's a really helpful finding. I think another important factor, I don't know if you guys were a recruiting site for this, we tried to be a recruiting site at Imperial, but we really struggled. We had a number of conflicting studies. We had Orbiter. We were doing the various IFR studies, including defined flare and then defined PCI and a number of other different studies. So we had difficulty recruiting into this study. But it's interesting to see that the centers that we're recruiting into the studies are perhaps not the kind of centers that you routinely think of. Around the world, there are centers from all over the world. And so it does truly reflect general cardiology as practiced around the world. And so I think we should sit up and pay attention to it.
Yes, no, excellent summary, Sukh. This was very well summarized. And I agree with you. I mean, there are differences in how patients get seen and throughput and reimbursement. And I think that's going to be different for different countries. But the overarching message for the study, at least to me, was, which is exactly what you said in your concluding sentences, that it's not imminent for patients with abnormal stress echocardiograms to be rushed to the cath lab. I think that to me was an overarching message. I agree that I think the computed tomography scan to define the coronary anatomy is going to have a new role.
Yeah.
Even though, the study wasn't necessarily designed to come to that conclusion. And I think there's going to be a drop, and there should be, rightly so, a drop in unnecessary stress testing, which, has been going on for a while, at least in the US.
Yeah, well, we are horrified when we hear, I mean, I occasionally have patients from the US here in London, and they say, I get my yearly nuke. And I'm like, what? Why are you having that much radiation exposure? What is it possibly telling anyone? And you may not even have coronary disease. Why is anyone doing this? And this is a historical fact, and this is just based on how things have grown. There are places in the UK that perform nukes and PETs. We've ditched it. Haven't done it for a number of years. It's in highly selected patients now. NICE guidelines changed in 2010, and we have essentially got rid of exercise testing for the majority of patients. Only use it to assess response to intervention, or for risk stratification, aortic stenosis or hypertrophic cardiomyopathy. We don't use it for the diagnosis of coronary disease, and so we've already moved away from those older-fashioned tests. We use CTCA a lot. I think it's useful in de novo presentations. I don't think it's that useful in patients with established disease. I don't think it should be used for monitoring. It's definitely not useful in patients with previous stents, although I know the newest scanners are better and better. I just don't feel that it adds that much. I think there's a degree of protectionism. I think in the UK, CTCA has been really pushed by cardiologists rather than radiologists. I know that's not necessarily the case in the US, and even in the UK, because CT usage has gone through the roof. It means that there isn't enough cardiologists to be able to report all these scans. So we've certainly got radiologists who are interested in the cardiovascular space, who really specialize in this field. And we work really closely with these guys and get incredibly good scans. And the scans, I think, should be used for where they have value, the negative predictive value. So if a patient doesn't have coronary disease, or it's only mild, or I would say even up to moderate now, I would now say that basically gives us reassurance that we don't have to do a lot of testing. Yes, I think we should give them a statin if they've got confirmed disease, confirmed plaque. Yes, I think they should probably have aspirin. I know the primary prevention data is mixed, but there is clear signal in the reduction of myocardial infarction. And if you've got confirmed soft plaque in an important territory, I personally want to take aspirin. And so, I think we've got basically a new paradigm for the future care of these patients, and then it means that we aren't wasting time in the cath lab doing normal angiograms or angiograms where the disease is mild, and we say, great, you don't need anything, and the patient is relieved. We don't have to have that moment. We can focus on doing more complex things and doing it well. I think the problem is, I don't know what it's like in your particular lab, but in our lab, when I was coming through in the early days, it was just a pressure to get volume done. And you'd have, 15 cases on the board for each lab, and you would be trying to get through them. Some of them would turn out to be normal, some of them would have complex disease, but it was a race to get everything done before the end of play, plus all the ACS work. And I would suspect that meant that the intervention performed was not the best it could be. It didn't have the level of optimization that it should have had, as we've now learned is super important. So I think that the onus is on us as interventionists to make sure that we do a good job, such that we are doing the best for our patients and making sure that the intervention is as perfect as it can be.
I agree with you. I think I've said this before. I think the CTCA, the computer tomography scan, is an excellent gatekeeper for the cath lab. And, it should be. And I don't think, old-fashioned stress testing has done a good job in being a good gatekeeper for the interventionalists. And I think, moving forward, like you said, it's going to be an important paradigm and a technology that will be used more often in screening patients, so that we can do the cases that need us the most.
Oh, absolutely. Yeah, absolutely. And I think although we really congratulate Professor Hockman and David Maron, who really led an amazing study, we do recognize that there are limitations. I think 25% of patients that are coming with exercise testing is a limitation. There is a high burden of diabetes, which is good because we want high-risk patients.
So thank you, Sukh. Thanks again for making the time for this podcast. This has been a fascinating discussion wrapping up 2019 for our listeners. Any concluding thoughts on 2019 and then how you foresee cardiology being practiced in 2020?
Well, Ankur, thanks so much for inviting me. I think when you look over all this data and you understand how complex cardiology is becoming, I can understand why people sometimes get bewildered and don't know how to add this data into their routine clinical practice. And I think that's the most important thing for us as practitioners and the listeners out there who want to actually apply these really interesting data into their routine work. And that's really hard. And I think true evidence-based medicine, I think people forget that evidence-based medicine is not just doing what the trial did, but is actually looking at the trial, bringing it into your healthcare system, looking at it with what the patient wants to do, and adding all those three elements together to be able to reach an answer and a conclusion. I think that's super important. I think people sometimes get a little bit fundamentalist about the application of RCT data. And I would say that the absence of information doesn't mean that something doesn't work. I would say that if something is negative, then we should respect that and not ignore it and not just keep doing the same thing all of the time. But I will say that healthcare systems are slow to turn and slow to move. We as a group of people, I would say, are relatively nimble, and we have the opportunity to put these things into our routine practice. But we have to steer the overall ship. We have to force healthcare systems that you work in, the hospital that you work in, your cath lab directors, your chief of services, your medical directors, to try and integrate some of this information to help our patients best. I think the key thing is that there's more studies than we know what to do with, and they sometimes conflict, and we have to basically muddle our way through.
Yes, I agree with you. I mean, I think it just, the world of anticoagulation and antiplatelet therapy and revascularization is a complex one to navigate, considering the amount of data that have recently come out. And, I think, that's why, conversations like these, just real-time conversations between two colleagues, bringing in patient care and our challenges, and I think is to me at least a useful platform for learning.
For sure.
For our colleagues and even for each other, I think it's
So I am struck by how good cardio Twitter has made my experience over the last few years, particularly when I go to conferences. It means that whenever I go to a conference, I will now run into somebody who I feel I know, not because I've ever met them before, not because I've ever spoken to them or even emailed them, but because their face comes up on my phone, sometimes several times a day. And whilst there are flaws with social media and there are difficulties, I think it is intrusive. I think it does lead to people misunderstanding each other and perhaps being less gracious as they should be. I think the real thing it does is breaks down barriers. So we, for example, got speaking in the faculty lounge at TCT, and I ran into so many people at all the various conferences this year that I would never have spoken to had it not been for Twitter. And then I think medium like this podcast, I think we all do long commutes. We're all traveling long distances. I think we all have an opportunity to sit and listen and learn while we're doing drives or using the transport systems. And so I think that this is a underappreciated media, and I think the job that you're doing with podcasting and having conversations and understanding where people have come from is really important. The conversation you had recently with Greg Stone was absolutely fascinating. Understanding his progress through his career, because we see him as a monolith, right? We see him as this guy who's on the podium at TCT and is directing all these massive studies, but he's like you or I, and he's come from a certain place and he's progressed his way through, and that's absolutely fascinating. And I think it's inspiring for cardiologists of all ages to have experiences like that.
Yes, no, I'm just thankful for the opportunity that I have through this medium, to reach out to colleagues like yourself, to educate myself, and in the process, help others get educated. And just track these conversations amongst colleagues, seniors, peers who, we read their papers and we know all about them. We know all about their professional lives, but I think it strikes a different chord, and like you said, it makes all of us more relatable when someone comes out with personal stories of how they became who they are or who we know who they are. So it's personally been very fulfilling and gratifying for me to record these episodes and bring them out. And thanks to colleagues like you and several others who've been very, very gracious, to us on Twitter in sort of helping us spread the word about the podcast. Because I certainly thought that this was a great medium for me to learn. So we just extended it, and I hope it keeps growing, in 2020, and we can
for sure.
Have more meaningful conversations.
I look forward to it.
Well, thanks again, Sukh. If I don't get to speak with you before Christmas or New Year's, very happy holidays and season's greetings to you and your family.
Thank you, and you too as well. For all those celebrating Christmas, Merry Christmas to everyone, and I hope everyone has a very happy New Year.
Thank you. I will speak to you soon.
Take care now. Bye.
Bye-bye.
Dear cardiologists, we want to make this podcast about you and for you. So please email us your critical thoughts, comments and questions at podcast@radcliffe-group.com and visit uscjournal.com for more information. You can also follow us on Twitter, LinkedIn, Facebook and Instagram at Radcliffe Cardiology for daily updates. Join thousands of cardiologists and become a Radcliffean by registering to radcliffecardiology.com. You will receive regular newsletters and gain access to hundreds of expert interviews, educational webinars, clinical cases, and peer-reviewed articles from our 6 medical review journals on general cardiology, interventional cardiology, arrhythmia and electrophysiology, cardiac failure, and vascular and endovascular surgery. Thank you.